Congenital Heart Disease by Julia Pian and Dr. Jaclyn McKinstry. Learning objectives. By the end of this video, the learner will be able to explain the pathophysiology for each of the diseases, recognize the physical exam findings for these heart defects, identify the different diseases based on imaging, and select the initial treatment plan. Introduction. The most common congenital disorder in newborns is congenital heart disease, affecting approximately 1% of live births. In this video, we will focus on cyanotic congenital heart diseases, which are lesions that allow circulation of deoxygenated blood in the systemic arterial circulation. The common cyanotic congenital heart diseases are often referred to as the 5 T's: Truncus Arteriosus, Transposition of the great arteries, Tricuspid Atresia, Tetralogy of Fallot, and total anomalous pulmonary venous return. All of these conditions require surgical correction, but a more detailed discussion of surgical management is out of the scope of this video. Truncus Arteriosus. In a normal heart, the truncus arteriosus is divided by the aorticopulmonary septum to create the aorta and pulmonary artery. When this normal septation does not occur, there is only one great artery to provide outflow from the heart. Blood flows from the left and right ventricle through a common semilunar valve and out through the truncal artery, which gives rise to the aorta and pulmonary arteries. The systemic and pulmonary venous blood flow are mixed. The oxygenation status and therefore level of cyanosis of the patient depends on the relative balance of systemic and pulmonary blood flow. At birth, pulmonary vascular resistance is similar to systemic resistance, so the amount of blood flow into the pulmonary arteries is similar to the amount of flow into the aorta. However, as pulmonary vascular resistance decreases in the first weeks of life, blood flows preferentially into the pulmonary artery instead of the aorta. This left-to-right shunting increases and the patient can rapidly develop heart failure. Truncus arteriosus presents as mild or moderate cyanosis in the first days of life or heart failure in the first weeks of life. On physical exam, the most common finding on auscultation is a loud and single-second heart sound and a prominent ejection click at the apex or left sternal border. Peripheral pulses are bounding and pulse pressure is often increased. As the child progresses to heart failure, chest X-ray shows cardiac enlargement and increased pulmonary vascular markings. Transposition of the great arteries. In a normal heart, the pulmonary artery connects to the right ventricle carrying blood to the lungs, and the aorta connects to the left ventricle carrying blood to the body. Transposition of the great arteries is caused by failure of rotation of the aorta and pulmonary artery during embryologic development of the heart. This leaves the aorta attached to the right ventricle and the pulmonary artery attached to the left ventricle, creating two parallel circuits. Oxygenated blood travels from the lungs through the pulmonary veins to left atrium, left ventricle, and then back through the pulmonary artery to the lungs. Deoxygenated blood travels from the body through the superior and inferior vena cava to the right atrium, right ventricle, and then back through the aorta to the body. Most infants present immediately with cyanosis. The degree of cyanosis is dependent on the presence and size of communications between the two parallel circulations that allow mixing, such as patent ductus arteriosus, PDA, atrial septal defect, ASD, or ventricular septal defect, VSD. To promote mixing of the parallel circulations, most infants are given continuous IV prostaglandin E1 or alprostadil. The condition is most often diagnosed by prenatal or postnatal echocardiography. Chest X-ray classically shows an egg on a string appearance due to the great arteries forming a narrower vascular pedicle when transposed. The mainstays of initial treatment include prostaglandin E1 infusion and balloon atrial septostomy to establish an ASD if it is not already present. The definitive treatment is an arterial switch operation performed in the first week of life when the transposed vessels and coronary arteries are dissected away from their valves and switched, restoring a normal circulation. Tricuspid Atresia. In a normal heart, the tricuspid valve allows blood to flow from the right atrium to the right ventricle. In tricuspid atresia, there is a congenital agenesis, or absence of the tricuspid valve, leaving no communication between the right atrium and the right ventricle. Blood exits the right atrium through the foramen ovale to the left atrium. Mixing of deoxygenated systemic blood with oxygenated pulmonary venous return in the left atrium results in cyanosis. The amount of pulmonary blood flow and degree of cyanosis are dependent on the presence and size of a VSD, as well as the anatomy of the great arteries. In patients without a VSD or with significant pulmonary stenosis, a patent ductus arteriosus is the only source of pulmonary blood flow, and therefore prostaglandin E1 is commonly administered.
Tricuspid atresia presents with central cyanosis and usually as a single second heart sound. If the patient has a VSD or pulmonary stenosis, a systolic murmur at the left lower sternal border may also be present. Chest X-ray shows lack of the smooth convexity of the right heart border due to the lack of filling in the right ventricle. Initial medical management focuses on general cardiorespiratory support and administration of prostaglandin E1. Surgical palpation is always needed to address tricuspid atresia. However, the timing and choice of procedure depends on the amount of pulmonary blood flow that is present.
Tetralogy of Fallot. Tetralogy of Fallot is the most common cyanotic congenital heart disease. The condition is defined by four major features: pulmonary stenosis, ventricular septal defect, overriding aorta, and right ventricular hypertrophy. The degree of cyanosis and other symptoms are dependent on the degree of right ventricular outflow tract obstruction caused by the pulmonary artery stenosis and ventricular hypertrophy. The greater the right ventricular outflow obstruction, the less pulmonary blood flow, and the more flow through the VSD from the right to the left. These changes lead to more deoxygenated blood in the systemic circulation and greater cyanosis. Tetralogy of Fallot is most commonly diagnosed prenatally by fetal echocardiogram. However, it can present postnatally with cyanosis or an asymptomatic murmur. Infants with unrepaired Tetralogy of Fallot are at risk for TET spells, where agitation or other factors can cause an acute increase in right ventricular outflow tract obstruction and profound cyanosis. Management of TET spells include placing the baby in a knee-chest position and administering fluids, oxygen, and morphine. Older children with unrepaired Tetralogy of Fallot will sometimes squat down or bring their legs to their chest to increase systemic resistance and decrease the right-to-left shunting through the VSD, thus increasing pulmonary blood flow and improving oxygen saturation. On physical exam, the second heart sound is usually singular because of a soft pulmonic component. A crescendo-decrescendo murmur with a harsh systolic ejection quality along the left mid to upper sternal border is due primarily to right ventricular outflow obstruction. Diagnosis is typically made by echocardiography, but chest X-ray showing a boot-shaped heart with an upturned apex and concave main pulmonary artery segment is also a classic imaging finding. Total anomalous pulmonary venous return. Total anomalous pulmonary venous return is caused by failure of the four pulmonary veins to connect to the left atrium. There are a number of different anatomic variants. In the most common variant, the pulmonary veins convene in a confluent chamber posterior to the left atrium and drain into the superior vena cava. This anatomy leads to mixing of the oxygenated pulmonary venous return and deoxygenated systemic venous return in the right atrium. The increased flow to the right heart leads to dilation of the atrium and ventricle. The partially oxygenated blood is shunted from right to left through an ASD, or less commonly through a PDA, resulting in cyanosis and early right-sided heart failure. On physical exam, patients with total anomalous pulmonary venous return have a fixed split-second heart sound due to right ventricular volume overload and often a systolic ejection murmur due to increased volume of flow across the pulmonary valve. Diagnosis is typically made by echocardiography, and classic chest X-ray findings include a snowman or figure 8 sign. Summary. As a final review, we will complete the following table to compare these common cyanotic congenital heart conditions. In Truncus Arteriosus, the aortic and pulmonic valves are replaced by a common semilunar valve and truncal artery.
Truncus arteriosus causes cyanosis at birth but then improves. It is not ductal dependent.
It presents with a loud, single second heart sound and a prominent ejection click at the apex. Chest X-ray shows cardiac enlargement and increased pulmonary vascular markings. Transposition of the great arteries is classically very cyanotic at birth, is ductal dependent, and does not have a characteristic murmur. Chest X-ray shows a classic egg-on-a-string appearance. Tricuspid Atresia is failure of development of the tricuspid valve. It causes cyanosis at birth, is ductal dependent in patients without a VSD, and presents with a single-second heart sound. Chest X-ray shows lack of the smooth convexity of the right heart border. Tetralogy of Fallot is defined by pulmonary artery stenosis, ventricular septal defect, overriding aorta, and right ventricular hypertrophy. It does not always present with cyanosis at birth, it is not ductal dependent, and is characterized by a single second heart sound with a crescendo-decrescendo murmur along the left mid to upper sternal border. Classic chest X-ray shows a boot-shaped heart. In total anomalous pulmonary venous return, the 4 pulmonary veins do not connect to the left atrium.
This condition does not always present with cyanosis at birth, is sometimes ductal dependent, and is characterized by a split-second heart sound and often a systolic ejection murmur.
Classic chest X-ray findings include a snowman or figure 8 sign. Thank you for watching our video on the 5 common cyanotic congenital heart diseases.